Merci. Ibrahim, everything okay. It's our experience of 244 cases of AVM, consecutive cases, which we operated and also we did with gamma knife surgery and also with embolization. This is my team, which I worked many years for this long cohort in time. And I continue to work in the private hospital in Bucharest. Is the name of the hospital is Sanador Hospital Center, with many disciplines and also with neurosurgery. In front of all neurosurgeons and you also, it's what we are doing. What is the best decision in AVM? What to realize, what to have perfectly quality of life and to have the efficacy of gamma knife surgery, of cyber knife was presented before. Yes, for very few data about congenital lesions, malformation, arteriovascular malformation with epilepsy, with headache, with this frequency. We all know this data. Generally, we receive young patients for this kind of malformation, vascular malformation. Epilepsy and focal neurological deficit are in all our data. And it's very interesting for our knowledge. The first AVM published was a French surgeon, Pan. This is Pan for Jean-Émile Pan in 1889. Important history, Gazi Yashargil, Gazi means victory, you know, and Donaghy for approach by microscope and also gamma knife surgery for Ladislav Steiner. We are very proud because Ladislav Steiner was born in Romania and is very great help for us to help us to realize gamma knife in our country. In history of AVMs, there are many personalities, many. I offer you this information and also Alexander Konovarov from Russia and other very good friends and very skilled in this neurosurgical field of AVMs. McCormick classification is the best and is clear in all vascular malformation in the brain. There are four important, and the cavernous malformation was the second, but first AVMs. You discussed before, Germano discussed before about special Martin classification is very interesting. This classification and change our paradigm of this malformation and with a good classification. And after that, Professor Lauter is changed a supplementary grading scale about the brain arteriovenous malformation. This is a good, perfectly good paramount idea about the pathology of AVMs, and this pyramid nidus, it's perfectly to obtain a good result. And Professor Yashargil demonstrated us in many situations and many lectures about the total excision of this AVM malformation. Operate or not operate? Operate. This is our job, to operate and to do all good things in that situation and to occlude totally the AVMs, because sooner or later MVMs will be ruptured. And for that, it's very dangerous for serious life. This is a Yashargil idea. This is Yashargil slides, which I received for his courtesy. And our data from two hospitals, when I worked, Baghdasar Arseni Teaching Hospital and Sanador Medical Hospital Center, 244 cases, all consecutive cases in 18 years. Generally, the males, young people are preponderant and the ladies. This is age distribution and superficial, supratentorial, most important cases in our data, which we have in the cohort of patients. Headache, motor deficit, seizures. There are three important data for clinical in our cohort, critical features in our cohort. Grade 1, grade 2, and grade C are most important. And this sure is a predictive outcome factors in that situation of AVMs which we treated. What we are doing is a multimodal treatment. And first option, microsurgical approach, embolization, and gamma knife. first option, 46%, 10%, and 43%. Yeah, because there are in the first option, but it's necessary the second option. After embolization, we are doing microsurgical approach. After embolization, we are doing gamma knife surgery. After microsurgery, sure, the same experience, you are doing gamma knife surgery in 32 cases. This is a lady, very nice, 27 years, with AVM basal ganglia, which first we are doing embolization, and after that we realize gamma knife surgery, and the results are good. I have seen this. I show you this situation. What we are doing is the question: gamma knife surgery, microsurgery, embolization? No. Every case has its own judgment. It's very important to know this and to continue about the discussion for every case in that situation. All the patients receive the anti-epileptic therapy pre-op and post-op. Some cases, which I try to present, this AVM grade 2 in the frontal AVM, please here, pre and post-op microsurgical approach. This is another with AVM parietal convexity, pre and post-op with total remover. And this is a lady, 7 years follow-up. Another case, a lady, old girls, 18 years old, with seizures, AVM grade 2 in occipital convexity, and 9 years follow-up with good recovery. Parietal convexity AVM, 16 years old boy with grade 3 is we realize a total removal in that situation, which I want to show you, like here. Yes, we go immediately with mirror is necessary. And the last point, the point which Gaziash has showed us in his many lectures and demonstration, is to close, very, very important, to close this venous drainage, last point of the OP. Yes, this is the last point and very important point for neurosurgeons. This is a gentleman, 16 years old, after OP, 9 years after OP follow-up. Another boy, which 18 years old, male with AVM grade 3, deep callosal situation with total removal, a lady, 53 years old with an AVM grade 2 temporoinsular lesion, difficult for OP, but the result was good. Here is a deep hematoma. It's an emergency attack. With immediately we realize that is a rupture of AVM. We have all the analysis, but not operating in emergency. We postponed till the brain was in good condition. After that, the surgery was realized and the lady was recovered with a period of neurorehabilitation. This is my OP with neuronavigation, with many facilities, also with gamma knife and embolization and everything in this private hospital, like in Baghdad Arseni Hospital. Dr. Shevnuk, who died, I regret totally, was chief of neurosurgical, vascular neurosurgical department with many procedures in embolization. One case is left parietal, grade 2, the lady is here, and another, a boy, 20 years, left frontal AVM, grade 4, and the results was good, but in many stages of embolization. Gamma knife surgery was realized, but my friend Professor Dr. Ferry Stoica, 100 and excuse me, hola, something is wrong, excuse me, am apăsat pe ce? Aha, bun, da, pe unde suntem? Jos? My jaws. Yes. And here is gamma knife surgery. Gamma knife surgery, we have the great help, which I said before about Professor Steiner with his courtesy, who was nearby us. One difficult case, AVM grade 3 in the frontal right, with good results in time and totally recovery. Another with left temporal AVM grade 2 with good recovery, and we follow up the cases. Without complication, only 94 cases and 6 with some complication, and sure it's not a viable. This gamma knife failure in many situations, we know that indication, and we stop not to enter in the big with great volume of AVMs for gamma knife surgery. We restricted the indication. The follow-up is 6 months evaluation, and in that situation appears seizures, continue before surgery and after all procedures, and cognitive deficit. These are the important neurological status after proceedings which we are doing. In the period of follow-up, 6 months to 9 years, the assessment is neurological, ophthalmological, EEG examination, sure, but MRI, angiography, and every case is spatial judgment, which I said before. Good recovery, 39%, but we have 2% into this because there are big AVMs, great volume, and the surgery was difficult in many other times with many difficult cases and the bleeding and other problems which all the surgeons know exactly. The quality of life is our aim now, to be very attentive on all the cases and very quiet surgery and to obtain good results. And the lady was in good situation after OP, total removal of the AVM. And appears many ideas in the literature. We are in connection with Bicêtre University Hospital for the embolization of AVM. The connection was perfect, and we received many good ideas, and also with Professor Lawton about this new kind of idea of embolization of venous part, transvenous approach for intracranial. Anyways, it's a new idea for us, like surgeons. We adopted these new ideas in AVMs. In conclusion, these AVMs are dominated by epileptic seizures, and microsurgical excision is very important, also with cerebral gliotic tissue. In functional areas, it's very important to know exactly where we are and to realize a perfect removal, not to destroy the good neurological area, and elective election. Major neurosurgical emergency in AVM with a hematoma, and any patient's epileptic seizure, progressive neurological deficit, hemorrhagic strokes must be fully investigated for possible AVM. We discussed especially in young patients, and these are part of our results, which we follow up in the same cohort, in the same 2 departments of neurosurgery, and really obtain general good results. Thank you for your attention. It's a beautiful and interesting, very interesting topic which we discussed today.